Okay, good afternoon from India. I work in Ganga Hospital, which is in south part of India, and we have a big hand department with 8 consultants. I am more interested in pediatric upper limbs, mainly doing cerebral palsy, birth brachial plexus palsy, and also involved in all the trauma cases. Today, I will be talking about Volkmann ischemic contracture, the management of them. And basically, what we are going to see is the art and science of restoring function in these very severe cases. I am sure this is a nightmare for any orthopedic surgeon. And a patient comes like this with a swollen blebs all around. It is really the most scary thing you can ever have in orthopedic practice. And these would eventually shrink in this way and finally lead to an Volkmann ischemic contracture. And we are going to see now how we go with stage by stage management of these cases to restore function in them. And this was a young boy, a doctor actually, and he had a simple fracture of the olecranon and probably a dislocation of the elbow as well. He didn't have much severe pain, but he gradually went into a Volkmann ischemic contracture, and we were really wondering whether he can be made functional. But finally, after doing multiple surgeries in him, this is he doing orthopedic surgery himself with all his students around. And he achieved really good function and he was able to do all the regular activities what anybody of his age and his profession would do. So that means it is not a real end of the world when you have a VIC, and there are very lot of surgical techniques available to make them function. However, still, I think the first impression or message from the talk should be that we should try our best to not have a VIC and prevent the compartment syndrome or a sequelae of it. But however, if you have had a patient like this, you need to be systematic and stepwise reconstruction to restore function in most of these patients. They would require persistence from the patient and lot of encouragement for the surgeon though. Now, the first question comes is, when do we operate in these patients? So when we operate, many times people ask whether you operate for that 6 weeks, 3 months, 6 months. But the basic thing is the skin overlying the area where you are going to operate should have healed in this way. Same patient at this stage, if we do any surgery, the skin would not heal and then it becomes an open necrotic muscles, which is much more complicated to damage, to deal. So we should allow the skin to heal completely and then we should go and do the intervention in these patients. The skin healing in general would take around 6 to 8 weeks. And once the skin is healed, then you go for reconstructive surgeries. Some patients, you may have total necrosis of the skin, and in such cases, the flap cover should be the first operation. In general, most of our patients with VIC would require 2 stages. The first stage involves excision of all the scar tissues to correct the contractures. Usually, these patients would have a wrist flexion contracture, so all the contractures need to be corrected. The neurolysis is done, neurolysis of the median and ulnar nerve. Usually the nerves are intact and they are encased in the sclerotic tissue, the necrotic muscles and the fascia. Once you have done a good neurolysis, you would be able to restore sensation and intrinsic function in most of the patients. However, some cases, the nerve itself may be damaged and the first stage allows you to document the proximal and distal end of the cut nerves. Then you get an idea of the status of the muscles. So these are the 3 things basically we try to do on the first stage. Muscle status would dictate whether the second stage is required or not. Mild cases and some moderate cases, a single stage is sufficient. However, in severe stages, you need to go to the second stage and sometimes even the third stage to restore the intrinsic functions. Let us take some few examples. This 7-year-old child, 6 weeks post-injury, we went in, We did a complete neurolysis of the median ulnar nerve and excised the fibrotic tissues. So this is the aim what we have at first stage. The wrist should become straight, the finger should be passively fully straight. This we should achieve at first stage. Now, this is the kind of fibrotic tissue one would expect there, which is called as a Seddon's infarct, and these all are dead muscles and they need to be removed. Once the neurolysis is done and the release of the fibrous tissue is done, then you take decision about what to do for the muscles. Now, if the muscles are quite good and have got a lot of functional content in it, at the same stage, we can do a fractional lengthening, which would give you around a centimeter of length. So mild contracture in the fingers can get corrected by fractional lengthening. However, in little more moderate cases, but still the muscle is functional, we can do a Z lengthening of all the tendons. Many cases you would find that the FDP is necrosed or fibrotic much more than the FDS. That is because the FDP is a more deeper muscle and always more severely injured. In such cases, we can just transfer the proximal FDS to distal FDP. This would correct the contracture and at the same stage restore finger flexion by the functioning FDS muscles. In late presentations where the patients have a flexion and pronation contracture, with all the muscles become shortened but still having some functional content, one of the good operations is to do a flexor pronator slide, which corrects the contracture and also retains the finger flexion movement what they have. Let us see another few examples. This is a patient who had a mild VIC. We did a neurolysis, and at the same stage with fractional lengthening itself, we should correct the contractures. And this is the kind of functional recovery he has. Because these patients would have good intrinsic recovery, and once the flexors are recovered, the hand function should almost look normal. Another, a little more moderate case, a young girl who came with a fixed forearm fractures with this kind of presentation at 4 months post-injury. We see that there is a flexion contracture at the wrist, all the fingers having flexion contracture, there is no intrinsic function, and loss of sensations for the both median and ulnar nerves. We did an exploration. This is the median nerve just at the level of the proximal third middle third junction where it pierces between the FDS and FDP. We can see that the nerve is tightly encased in the fibrotic tissue there. We did a thorough neurolysis and all the FDPs were looking very fibrotic. Hence, we transferred the proximal FDS to distal FDP in this way. We could get a strong repair and hence we allowed to do an early active mobilization. And this is the kind of result you can get. These are only the FDS functioning. Reasonable amount of finger flexion and power can be attained in these patients. And we can see that the contractures are completely corrected. If the flexors are working and patient is presented after a long duration, all the flexor muscles would be shortened, but they would be functional. In such cases, we prefer to do a flexor pronator slide, which addresses the flexion and pronation contracture both, and same time the neurolysis also is done. We can get a good result by this operation as well, but this is much more extensive than any other operations because you need to start at the medial epicondyle and we need to erase all the flexor muscles till the origin of the flexor pollicis longus, which will be somewhere in the middle third of the forearm. But this gives quite a good result. However, if the patient falls in the category where there is no functional flexor mass available, we need to resort to one of the two options. Either we can do a tendon transfer of the extensors to flexor, or we need to choose for a free functioning muscle transfer. So we feel that after doing a flexor release, once we leave these patients and they are allowed to do good wrist extension, then only we understand the true extension power in them. If both the ECRL, ECRB are working and finger extensors are working, then we do a ECRL to FDP transfer. However, if the extensors also are involved, then we choose to do a free functioning muscle transfer in them. You can see an example here, a patient who had a ECRL to FDP transfer and brachioradialis to FPL transfer, can get a good result, full, almost complete flexion, full extension, and good movement of the thumb. Very important to time this procedure correctly. And ideally, the operation should be done when the intrinsic recovery has happened. So we did the first stage of neurolysis and contracture release. In 3 months, we could check that there is a good recovery of the intrinsic muscles. And when intrinsic muscles have recovered, that is the time that we go for the ECRL to FDP transfer. Because without the intrinsic muscles, the transfer of ECRL to FDP would not look like a good functional. It would give a good finger flexion. However, the overall flexion cascade would be missing. So the time to do this transfer is when the intrinsic muscles are recovered. This is the kind of result we could get in this young girl at 3 years post-surgery. Good flexion, good extension, and good hand function, which allowed her to do all the normal activities what a child of her age would do. You can see here, she is able to pick up even small things and go on to pick up bigger things. And she feels that she is quite functional and back to normal life. If all the flexor muscle mass is lost and the extensors also are involved, I think the best option is to do a free functioning muscle transfer. In these cases, we will have a good nerve available proximally, and always the anterior interosseous nerve is our donor for the free functioning muscle. Anterior interosseous nerve, we know that it is not involved at the origin in the VIC contractures, and it is always functional, and it is a motor branch, so it is going to activate our gracilis quite well. And after a free functioning muscle gracilis, you can get a good result. This is a patient, an example of a severe VIC. We can see there is no muscle mass here. Child has got a flexion contracture there. And also the extensors muscles were not good in him. This is the muscle outcome at 1 year. This is the kind of range of flexion you can get in these patients. This was much more severe case, and still the patient is able to do reasonable amount of finger extension and good finger flexion, which allowed him to use the hand for all his day-to-day activities. And he was quite happy with this outcome, and he was back to his normal life, driving bike, lifting weight, and doing a work in his farmhouse later. In younger children, I think the results come much more better. This is a young girl of 8 years where we have done a free functioning muscle transfer in the second stage. This is the result at 1 year, and she's back to all the normal activities. The good thing about gracilis is it has a good excursion, and the range of movement what we get would be great. And hence they would be very happy with the outcome. ECRL to FDP can get good flexion power, but sometimes the range may not be so great, and they still keep using the wrist tenodesis to get a good finger flexion and extension. However, with gracilis, the patient would have a good finger range of movement and no contractures, and especially in children, they would have a very good result in long term as well. So this is one of the most severe VICs we have treated. It was almost about 15 years back. This patient presented with this state, and this was quite terrible to see. She also had a complete necrosis of the bones. One of the most adventurous cases what we have done, flap cover, then a free fibula for him to restore the bone length, and finally tendon transfers and free functioning muscle transfer to get this level of finger flexion. But the most stunning thing is this girl finally went on to become a doctor, and now she is a full-fledged doctor and practicing medicine. So that means when you have a patient with Volkmann ischemic contracture, yes, it is a tough thing, and we should make all the efforts to prevent such a sequelae. But if it happens, then there are a lot of reconstructive options available now. We need to be systematic. First, tackle the skin. At first stage of surgery is done when the skin is settled. And during the surgery, you take care of the contractures and also attain a good neurolysis so that you can get a good intrinsic muscle recovery and sensory recovery. And once the intrinsic muscle recovery has happened, then we go for the muscle transfer, ECRL to FDP, or a free functioning muscle transfer. However, if the nerve is completely lost, many times we will require to do a nerve graft as well. However, most of the patient, we would be able to offer something and we can get a good functional result in most of them. Thank you so much.
Thank you very much, Dr. Bhardwaj. How do you pronounce your surname?
Yeah, Bharadwaj is correct. Bharadwaj.
Bhardwaj. Bhardwaj.
Yes.
Bhardwaj.
Yeah.
Perfecto. So really nice presentation. Really systematic as usual. Kevin, would you like to moderate this talk? If you are there. Otherwise, I will do. Okay, I will do. Okay, so one question. I've
Yes.
seen a few cases of patients with post-fracture contractures, mostly the deep compartment, but they were like subclinical. And in all of them, what they had was pain, long history of pain, not really a high level of pain. Do you have experience with that subclinical Volkmann contractures?
Yes. Yes. I think, yeah, you are right. The subclinical contracture is common, especially in children. I think they do react with pain, but they try to not tell much about pain, fearing that they will get some injections. And they can have a very subclinical infection, the compartment syndrome, basically involving the FDPs. And you would see that you see them, these patients after 3 or 4 months, they would have a mild contracture of the FPL and sometimes the contracture of the middle two fingers, because these are the deepest of all the flexor muscles. Yes, they can happen and they would also eventually lead to the sequelae like a VIC.
Okay, the same experience. Are you? I haven't looked at that, but are you aware of any papers or publication about these subclinical Volkmanns?
No, I have actually not read any paper about this. I don't think there are much publications. And personally, we would have seen maybe around 3 cases, if I could recollect them. Yes.
Okay. One more question. Have you ever done a one-stage gracilis transfer in this kind of patients? So when would you consider to do one stage?
Yeah. So one stage, gracilis, we have never done. One stage we do only for the mild VICs. So the first stage is basically aimed at exploring neurolysis of the nerve and seeing the status of the flexor muscles. If the flexor muscle mass is good and the contracture is not very severe, we do a fractional lengthening or an FDS to FDP transfer, but that applies only to mild and moderate cases. Then it becomes like a single stage reconstruction. But if whole of the flexor muscle mass is lost, then we always go for a second stage, either an extensor to flexor transfer or a free functioning. We never do the gracilis on the first stage here.
Perfect. What percentage of successful gracilis transfer for finger flexion do you have? So how
Yeah,
many of those children has a functional grasp?
yeah.
More
I
or
think
less.
the survival of gracilis is more than 90%, and useful finger flexion could be attained in almost 80% of the patient. If
80%.
I have to say a number, yeah. Yes.
Very good figures. And one more question. Have you needed in any of those patients myotenolysis of the transfer of the gracilis?
Yeah, we didn't require a myotenolysis, but in few patients, specifically to tell 3 patients, we had these patients developing a wrist flexion contracture as they grew. And that is, I think,
Ah,
a problem, especially it is one reason maybe the growth, other reason maybe the contracture of the flexor tendons. And out of these three, two patients we could manage by doing the the tenolysis of the flexor tendon and release of the flexor muscles. One patient we required a proximal row carpectomy to correct the flexion contracture. However, one patient it was so severe that we required to do a proximal row carpectomy and fuse the wrist. So this can happen if
okay.
the gracilis and contracture, gracilis is done in much early young age and there is a contracture on the flexor side.
In one patient, I did a mistake. I didn't evaluate properly the wrist extensors, and I transfer the ECR B to the FDS, and I lost, not completely, but I lost some wrist extension. It was a disaster. I can't for so
Oh,
one message is if you do a tendon transfer, evaluate the wrist extension strength, right?
true, true. Yes. Think we need to be very careful about that because loss of active wrist extension would drastically reduce your functional activities.
Because
Think
in
one
some of
good examination trick in that is any patient who has good finger extension or thumb extension would almost always have a ECRB working. If the finger extensors or thumb extension is not good, then we need to be really suspicious that the ECRB is working or not. That may be the extension,
Mhm.
maybe only because of the ECRM.
Because some of those patients has also the dorsal compartment involved.
True, yes.
Um, how do you diagnose that? How do you suspect that?
Yeah, so we do the first stage of surgery and then leave the patients for 3 months. And at 3 months, if the patient does not develop a wrist flexion contracture, he is able to do good wrist extension, then only we think that the wrist extensor power is good. If the patient is developing a wrist flexion contracture, that means the wrist extension power is not good and he is likely to lose the wrist extension if the ECRL is taken for the transfer.
Yeah, and just two more. One more question. Most common donor vessels and nerve.
Yeah, most common donor is the anterior introitious nerve. And the vessel, usually we do an anti-side to the brachial artery.
And to say to the record. Okay, so the muscle crosses the elbow. We miss you, Dr. Barge.
So anti-side brachial artery and anterior introitious nerve.
So the muscle crosses the elbow joint.
Yes. So we do the
Okay.
attachment of the gracilis either to the medial condyle, supracondylar ridge medial side, or we even can even do with a drill hole in the humerus so that we get a good hold. It crosses the elbow.
Okay, thank you. Let me check if there are some questions here. Okay, so Takehiko Takagi asked, when you do decide between fractional lengthening or muscle sliding?
Yeah. So fractional lengthening we do if we know that the fractional lengthening is going to give increase in length of only a centimeter. Now, if the patient has got a very mild flexion contracture of the fingers, very mild, I think if I can give an example is in neutral position, patient should be able to fully extend passively. But when we extend the wrist, the fingers are flexing. So these are the only cases where the fractional lengthening would be sufficient. If in neutral wrist, we are not able to passively extend the fingers, that means the fractional lengthening would not be sufficient. Then we choose either Z lengthening, if the FDS and FDP both are good, or we do an FDS to FDP transfer. Because we need to keep in mind that these muscles are not normal muscles and they are likely to have little more contracture as the child is growing. So it is better to overdo the lengthening rather than underdoing.
Great. So the Volkmann's angle 0 is your cutoff
Cut off for the
figure. Okay.
fractional lengthening, yes.
Volkmann angle 0. Okay. And then one more question. How do you assess contractibility intraoperatively of the muscle?
Yeah. So more than contractibility, we see one is the color of the muscle, other one is the glide. So if on taking the tendon and trying to see a distal glide, if the glide is good, the muscle is nice. If the glide is not good, then the muscle is not going to function well, and it is again going to go for a contracture. So we assess mainly based on the muscle glide.
So gliding more than contractibility and color, right? Gliding, nice. Any complementary exam to assess the viability of the muscle? Because I remember some years that I tried with the radiologist to do the same gammographies that they do for, gamma scan that they do for the heart to assess
Oh.
but do you
Yeah.
have any experience about that? We didn't get to any conclusion, but
Okay, that is very
any
interesting. That's very interesting.
ideas?
We never tried actually, and I am not aware of any technique of doing that as well. Yeah.
Okay.
Yes.
So, I think we are done. Thank you very much. I really enjoyed your talk.
Thank you. Thank you so much.
I'm not
Yeah.
trying to be kind, but I really enjoyed a lot.
Thank you. Thank you.
Thank you very much.
Thank you.